Welcome back to Tumor Board with Hilario and Anish. I'm your co-host, Anish.
And this is Hilario.
This week on Tumor Board, we talk to Dr. Anna Lee. Dr. Lee is a radiation oncologist at MD Anderson Cancer Center. She specializes in the treatment of head and neck cancer, but more importantly, she has been an advocate for gender equity in oncology. As you'll learn, she is one of the early founders of the Society of Women in Radiation Oncology, a group dedicated to discussing issues for female practitioners. And we discuss her new study related to family planning and fertility amongst oncologists. And here's our discussion with Dr. Lee. So Dr. Lee, welcome to our show, Tumor Board. We're excited to have you.
Yeah, thank you so much for having me.
So Dr. Lee, I had reached out to you because I saw a post by your colleague, Dr. Fumiko Chino, and it was about your study titled Family Planning, Fertility, and Career Decisions Among Female Oncologists. And it was published in October 2022 in JAMA, the Journal of Medical Oncology. And we thought it was really interesting, and we're definitely going to discuss a lot of the paper in the episode. But when I further looked into your career a little bit, and I've seen some of the other studies you've published, it seems like you've done a lot of work in this under-researched space of family planning, gender equity, fertility in the oncology space. So can you tell us a little bit about your background and how you became interested in this particular area?
Oh, yeah, sure. So when I was a resident, I had a co-resident in my program, Virginia Osborne, and she was in the process of family planning and looking for maternity leave, and finding that there wasn't a lot of guidance in that space, and even having to discuss with our program director about how much time she could take off, and sorting out those details. There really was not a lot of information out there about how programs should manage these sort of situations. And so, we would have discussions in our resident room, and we felt like there was a need to mobilize to advocate for female residents. And we felt like there was really no group out there that we could associate with while we were in training.
Right.
And so she founded SWORO, which is a Society for Women in Radiation Oncology, and I was involved with the early development of this. And through these efforts, we started looking into the experiences and concerns of female residents, and we developed and with the goal of promoting gender equity. And so very quickly, there was this huge interest. I think out of this, there was more interest in the AAWR, which is the American Association of Women in Radiology and Radiation Oncology. You may have heard of RADONC Women's Physicians Group. So this is a Facebook group where a lot of women have started joining to discuss cases, to discuss different career-related situations. And then we also have SWORO now, which is focused on residency level and trainee level issues. So there's been a lot that's also spawned out from the COVID pandemic. So it's been a very fruitful and interesting time.
Interesting. So how did you kind of get from there to this specific study? Was there preliminary work you've done? Because this is, this specific study was a very large study. There's a lot of people who took this survey.
Yeah, well, through SWORO, we had done a resident survey, and out of that, concerns for maternity leave came out, even during the COVID pandemic. As y'all may be aware, the ABR board exams were canceled. And then from that experience, there was a lot of backlash in terms of women feeling like, I did family planning to plan around the ABR. And so from that experience, we felt like there weren't many options for us in terms of, flexibility. People were, sharing on Twitter and in public forums that, they had to like pump in the bathroom during the examination breaks. There were just a lot of underlying issues that were being exposed through the COVID pandemic. And so I was training in New York City as a fellow at that time, and even just having these conversations with my colleagues, we're all young female oncologists in our
Right.
childbearing years, and it was, in those environments there, people are just much more open about talking about, oocyte preservation. They'd be like, yeah, what are you doing this weekend? I'm getting my eggs frozen. They're very open about that. And so um I mean, I think part of it has to do with the fact that in in New York, a lot of institutions have support, insurance support for those kind of procedures. And so
Mhm.
when we were talking about that, we realized that this may not be commonplace in a lot of places, and women's experiences may not be similar in different areas. So we wanted to explore that. And so that's how this survey came about.
That's very interesting, Dr. Lee. Female oncologists are often spending their childbearing years in training and also trying to establish their careers at the same time. By the time people really feel like they've had a footing in their careers, usually like in the late 30s or mid 30s, and it's the times where people experience fertility issues, right? So I was seeing the rate of infertility is like as high as like 30 something percent versus the general public, where it's probably around like 15 to 18%. The attitudes around like, trying to support our female oncologists, I feel like that's not something that we really see a lot of during residency. And so in trying to do this study, what do you think were your barriers that you thought you would probably encounter in trying to gather the data for your research?
Yeah, that was a challenge in terms of, we were developing this survey. We were talking to fertility specialists at our
Mhm,
institution at Memorial Sloan Kettering, and um, trying to figure out, what are some questions that we could ask that would really help us understand all the different types of issues related to fertility and family planning. So we tried to separate or group the questions based on the barriers to family planning when it came
mhm,
to one's career, to understand the association of fertility treatment options with career decisions, and then also pregnancy based discrimination, specifically related to like maternity leave and things like that. So um, I think one, even though we vetted the questions, we had several groups of people look at the questions and make sure that we were addressing all potential scenarios. We still
mhm,
didn't capture everything. After we published
right.
the survey and we sent it out, we would get emails like every week. Somebody would be offended about a question, or somebody would be like,
Oh,
well,
wow.
I have a husband who's a stay at home dad and he's a
Mhm,
primary caregiver. And, one of your questions didn't have that answer choice.
Hmm.
And, it made me realize how, even though we think we're very open minded and we try to account for every potential scenario, it's very difficult to do that in a survey study. And so there are limitations associated with that. And also
mhm,
helping me realize, oh, wow, I am kind of narrow minded in some respect in trying to think
mhm.
of, what the potential
Hmm.
scenarios would be.
Gotcha, gotcha. Yeah, that must have been very enlightening. Just getting
Yeah.
feedback from people about your survey. I was recently, um, in the past year, I was doing a study on sexual dysfunction
Mhm.
amongst like female and male patients after like rectal or like anal cancer, and
Yeah.
it's just I just left a space just for them to write anything, and I just kind of showed me how much I'm actually not capturing in those questions that
Mhm.
I've asked. A lot of ideas that you get from that alone can like help build another whole study
Yeah.
or continuation of your study down the line.
Mhm.
Did you feel like there was any hesitation or like any kind of like insecurities that came out from practitioners around your study, so that people either didn't want to respond, or if they were responding, it felt like people weren't truly being honest because of like stigma or like fear?
Mhm. Well, a lot of the questions were very sensitive. They were making
Mhm,
you, some of them were asking you to recall, what kind of complications you may have had related to
mhm,
pregnancy. Some of, they also asked about like miscarriage rates. And these are all kind of potentially
Hmm.
triggering questions. So I
right.
think we were trying to be very mindful of that, but we also wanted to capture all that data to really report, all the roadblocks and the difficulties that women go through while they're trying to balance their career and grow family. And so we do think that there probably was some response bias. People wanted to write in socially acceptable responses, even though they know that this is a completely anonymous survey. And then also,
Mm-hmm.
some of the women in some of the respondents were later in their career who had already grown
Mm.
children, so there may have been some recall bias as well.
Gotcha.
Mhm.
Gotcha.
Mhm.
We're talking primarily about female oncologists. Who else was your target group? Besides female oncologists in the childbearing age group, who else did you try to include in this study?
Yeah, I think that's a good question because one of the reviewers' criticism of this study was, why are you looking at oncologists, or what is it about oncologists that you think is different than other female physicians? And actually, we
Mm-hmm.
don't think that oncologists are that different than other female physicians, but it's I think for us, it was kind of a logistical issue trying to manage a survey
Right.
and trying to,
Right.
it's very difficult to survey, all of female physicians. And so, we kind of used it as a microcosm of what's going on in the general, female physician population. But,
Mm-hmm.
it was primarily because all the authors were oncologists and that was our networks. And we think that probably most of the people who responded were, um, in academics or in hospital-based practices, because that was just
Mm-hmm.
our network through social media and Facebook groups and just email chains. So
Right.
yeah,
Right.
just we wanted to capture really all female oncologists, whether they were of childbearing years or even later, who are post childbearing
Mhm.
years, who could just share their experiences.
Gotcha. Gotcha. It's easier because also you're in the community of like oncologists as well. So it's probably easier for you to disseminate your service to those societies that you're familiar with. I guess a question that I have is, what specifically were you surveying, or what kind of questions were you asking? And do you think that there any avenue for you to be able to ask like male oncologists who may also have put off having children, but they're not carrying babies, right? But
Right.
their wives are waiting for them. Because I'm saying that because in my scenario, for example, I'm thinking, okay, maybe I want to finish residency before I have a kid, or maybe I want to reach
Mhm.
year 3 of attendantship, so I don't want to have a kid now. And then I realize by the time I get to say 35, and then I want to have a kid, maybe some issues come up with my wife or with myself. Like, what kind of questions do you feel like you're asking that?
Yeah. So, as I mentioned before, we did divide up the questions based on three main areas. So, related to fertility, family planning, just your attitudes, and then about assisted reproductive technology and if anyone their experiences with that, and then also discrimination.
Mhm.
So
Mhm.
Mhm.
we asked, broad based, like what are some positive factors associated with family planning, what are some negative factors associated. We had a bunch of factors. And then for a lot of the questions we did allow for open text or free comment
Mhm.
sections. And then we asked specifically about, I thought probably one of the most interesting areas was about discrimination, you know,
Mhm.
um,
Mhm.
about, you know, did you ever feel like discriminated versus like, did anyone explicitly say anything, trying to tease out those nuances. And then also just overall issues. Just we want to get baseline rates about, how often miscarriages were happening, or how often they female oncologists were experiencing those, or what percent of women had to deal with infertility or require some sort of counseling or treatment. So there were a lot of questions. I don't think we didn't, use all the questions in our report or in our publication, but we're doing a couple sub studies based on that, based on the
Mhm.
remaining information, so that we can really utilize everything that we have and use the information that all these women have shared with us to better inform the public.
Mhm.
Mhm. Dr. Lee, you've mentioned now a few times pregnancy based discrimination. Can you just define what that is and what you found related to that?
Yes, that's a good question. So, we found in our study that a third reported experiencing discrimination during pregnancy, and then another third stated that they experienced discrimination for taking maternity leave. But I think that's a great question, is how do you define discrimination, right? Because, in this survey, we're asking the people who, presumably carried the child, or, they were
Mm,
the ones taking maternity leaves, what they experience. It's their lived
mm,
experience.
Okay.
And so,
mm,
we
Mhm.
didn't clearly define discrimination in our survey. And, for women who, responded that they felt discrimination, is just, they reported what they felt. It was kind
mhm,
of a
Yeah.
binary question, yes or
mhm.
no. I think discrimination, it can be kind of difficult to define in a
Mhm.
survey study, in a survey setting. I think what's important is we report what we find, or what, the women shared with us, and then it's really up to us to determine what we're going to do with that information.
Right. Right.
Okay.
Right.
Yeah. What you said, especially, being asked to return early from maternity leave, and that is, I'm sure, very stressful on any parental unit. And it seems like that is, I think the idea of that can also be a barrier in terms of, family planning. If they feel maybe the culture is not appropriate, or maybe they just aren't able to take a few months of maternity leave that they should be entitled to have. What are some of the other barriers you found? You alluded to timing of boards, and some women seem to have had to even pump breast milk during, in between exams and whatnot. What are some of the other barriers that you found women face when it comes to family planning and career decisions?
Um, so we did have a question that asked specifically about all the potential negative factors associated with,
Hmm.
what about women's fertility and family planning experiences. The most common negative factors associated with fertility planning were long work hours and heavy workload, followed
Mhm.
by concern for fertility or biological clock, and then income for trainees, and then lack
Hmm.
Right.
of nearby family support, which probably has to do with, providing adequate childcare, and
Right.
then, non-existent or bad maternity leave policies. So I think it's multifactorial and multi-level. So, for trainees, obviously has to do with, at the institution level, you're not getting um,
Hmm.
mandated, paid leave or even protected time. Um, and the thing with a lot of policies is that there's a lot of policies written out there. Some are suggestions. Some institutions feel like, and also I don't feel like there's good oversight in terms of enforcement of these policies. And so a
You're
lot of,
talking about policies by program specifically,
yes, or
correct?
even if a society, like if
Hmm.
the ABR is, if or not the ABR, but like the Board of Medical Residencies, if they're stating a policy, it may not be something that's immediately rolled out. It takes time,
Mm.
or
Mhm.
sometimes it can be just a very strong recommendation. And so,
Mhm.
really,
Mhm.
it's up to institutions and departments to enforce those policies, and
Mhm.
to ideally, develop their own as well, to help um, support women in terms of um, finding the time to bond with their child in the immediate post birth um, period, and also giving them the financial support. Full paid
Mhm.
maternity leave is very rare, it's hard to
Right.
find. So
Right.
even that, and then
Mhm.
adequate time. So um, and then, in the home, I think there's other factors too, having a supportive partner, um, having family nearby. Those are other issues too. But there's, it's just, really the ones that we wanted to highlight were the systemic issues.
Mhm.
Mhm. How about, like, how does potentially national policies or state laws come into play? Have you found that these have had an impact on this as well?
Yeah. So, New York State has full paid maternity leave. I believe it's for 2 to 3 months. I'm not exactly sure the amount of months, but
Mhm.
it's pretty much mandated. So it's a
Mhm.
great, I think I've seen some friends who have taken advantage of that. They're like, oh, I really want to take advantage of this, or they feel very motivated to grow their family during the time that they're employed there. Um,
Mm-hmm.
Mhm.
I think it does make a huge difference because I think, they're also very supportive of, making sure that it's also for paternity leave, right? And,
Right.
Gotcha.
that's another level of support that
Mhm.
not all institutions offer. And I think that once you
Mhm.
normalize that it's maternity and paternity leave, I do think there'll be less discrimination for women in the field just because our counterparts are also able to take leave and support their families, and also,
Mm-hmm.
decreases those ideas of social norms that we play into.
Mm-hmm.
Mhm. Do you think there's a difference between private practice jobs and academic jobs, and in oncology and maybe even outside oncology when it relates to these kind of policies that they may have?
I think potentially I'm not that aware of how private practice,
Mhm.
how those benefits and um, how leave works in private practice as much, but I do think in academia, I think because there's more institutional level policies, and in some institutions there's
Mhm.
also like we have like faculty senate. We have groups
Mm-hmm.
that can mobilize and advocate for the things that we need. I do think
Mm-hmm.
that
Mhm.
there's avenues and ways for us to um, advocate for ourselves.
Right.
Okay. So, one thing that really struck me about what you had published is the pregnancy complication rate. And, you've highlighted about two-thirds had some type of pregnancy complication, more than one-third had two or more miscarriages. And it seems like, a sizable portion has had tried to pursue some type of fertility treatment.
Mhm.
It seems like some of the barriers are really include even this kind of financial burden to pursue these treatments, even schedule burdens, right? You have to clear your schedule to even have your doctor's appointments,
Mhm.
go to the fertility clinic. What did you find regarding fertility treatments and pregnancy complications, and how did that relate to some of the decisions that maybe these survey responders made?
So, first of all, I think there's a lot of women who reported that during training they didn't know anything about assisted reproductive technology. They didn't even know that
Mhm.
what the options were. They didn't know the differences between like oocyte preservation, IUI, IVF. They just didn't know. And
Yeah.
no one told them, you're young now, maybe you should freeze your eggs, right? So a lot of
Right.
women reported um feeling like they wish they had known about it, or they wish they had more information about it, or it would have changed their behaviors, or it would have changed something, they would have taken more
Mhm.
steps to preserve fertility. So um I think the results showed us that um it's not really talked about in the trainee level, and that's kind of the perfect time to start discussing it, even in medical school. And um and, by discussing it, I think that it will help women try to navigate, their career planning as well. Because I mean,
Mm-hmm.
they kind of help,
Mhm.
they're very much related and intertwined. So, um, it informed us that it needs to be, the education needs to start early, but also,
Mm-hmm.
um, institutions need to start, they really need to be able to offer that at an insurance coverage level. So,
Mm-hmm.
Yeah.
New York has a great insurance policy to be able to do that. Texas, I'm not sure about Texas state as a whole, but our institution at MD Anderson started offering coverage last year. So that's
Oh
new.
Mm.
wow.
And I do think that it's still not widely known. Recently we had
Mm-hmm.
like a female luncheon and we were talking about that, and people were like, "Oh, I didn't know about that." So I think it's still not widely known or
Mhm.
talked about. So um but it really does change people's ability to um their options, trying to figure out, okay, like Hilario, you were talking about, like, I'm starting to think about, like, when is this going to happen for me? Um
Right.
and I love that because I think that there's, one comment I remember getting in the survey was somebody asked, "Have you looked at these attitudes in men. And I think
Mhm.
that is a
Mhm.
very important study that needs to be done because,
Yeah.
um, by just asking women, we're kind of putting the onus on women, right?
Right.
But,
Right.
in heterosexual relationships, it would also, this is also something that men need to think about. And,
Hmm.
it by, you know, really being invested in it, they're also, creating a more equal partnership.
Right. Right. Yeah, that was kind of my thought behind the question earlier on,
Mhm.
is that I feel like a lot of like you know discrimination based like issues that we see, whether it's in society or like in our case medicine, like if the people who are discriminated against, or if the people who are at some kind of a disadvantage are primarily doing their work all the time,
Mhm.
then
Yeah.
I think it's like a bigger mountain to like kind of get over than say like men, if men are thinking about how they can do paternity leave and be there for their children, but they're gonna realize that, oh my god, our female counterparts have been talking about this all the time and we never really listen to them, right?
Right.
Because a lot of these policies, a lot of these policies or lack of policy, right? It's probably because it's a lot of people making decisions around these things are men, right?
Mhm.
If you're in a male dominated field, uh, um, pe- men do not think about these things because traditionally we've made this a woman issue, right? And so their biases are set into not really thinking about this stuff. And I think one of the things is that we can kind of co-opt men into thinking about this a little bit more, and also supporting our female counterparts, and also for themselves as well.
Mhm.
um so we've talked about some of the findings and going down to the impact on like people's career. What do you think is the impact on like promotions and like job satisfaction? You alluded to like you know people thinking about their insurance. What kind of insurance is available for them? How does that, do you think, affect people's promotion and job satisfaction in general?
Yeah, actually, there was a recent paper out. I don't recall if it was, I do believe it was, came out right before, very close or right before our paper came out. And they looked at
Mhm.
US female oncologists and found that over 20% consider leaving academia in the next 5 years, given the gender
Mm-hmm.
inequality, specifically associated with promotion and a sense of
Mm-hmm.
Wow.
belonging in their work environment. So we feel like, because we do feel like this is a concern, and that women are feeling discrimination for fertility, who face discrimination for fertility concerns. And it starts early. It may be a resident felt something during residency, felt like they weren't being
Mhm.
supported, and they thought, I'm not going to go into academia because I feel like I'll have more control over my schedule if I go into private practice. They
Right.
it
Mhm.
can inform their career change and their career decisions. So it is really important to be able to level the playing field, and making sure that deciding to have a family or deciding to take maternity leave doesn't set you back.
Mhm, mhm.
Mhm.
Yeah, and I guess the opposite on the other end is that people who, are who are very career oriented. Do you feel like that there's like a penalty on them? So now you're
Yeah.
very career oriented, right?
Mhm.
And but then you're not in a very supportive environment, right? So you have to pick one or the other. So
Right.
people who are career oriented, did you find, or what's your inclination on like how they're penalized for being career oriented without really getting that support?
Well, in our, we were looking at some of the, in our study when we were kind of analyzing this, a lot of women who are very career oriented sometimes may end up being involuntarily childless because
Mm,
they were focused so
Mhm.
much on the career, and then by the time they decide, okay, I made it in my career, now I want a family, it's too late, because we have
mhm,
that
Mhm.
biological clock. Um,
Mhm.
and actually, when there are studies out there showing that um, there are women obviously who want to take that career path who decide not to have children. But,
mhm,
um, there was a survey study showing that, most women do want to have children, and the women who want to have children or who end up having children, they find an immense amount of satisfaction and find that experience very rewarding. So,
mhm,
um,
Mhm.
you know, obviously, growing a family, having a career, and or growing a family and deciding to um, pursue that is very personal decision. And
Mhm.
there are, I have very good friends who decided, they
Mhm.
made that decision not to have children, and that was the decision for them, best decision for them. But really it's about the ability to have that choice, right? The ability
Right.
to decide, okay, well, if I want to pursue a career and I want to pursue a family, you know, pursuing a family should not be a detriment to pursuing or having a successful career.
Right. Right.
Mhm.
Yeah. So moving into advocacy, right? So oncology happens to be one of the specialties where we actually have more women, right? It's like around 58% apparently versus 42%. How do you think, men and women within this profession can kind of come together? How do you think we can come together to kind of advocate for better conditions around family planning and fertility?
I think, I was just thinking about this, just came to mind because of, what you were saying, Hilario, how you feel like about, men's attitudes. I think we need to
Mhm.
do research on men,
Right.
men and fertility. Like,
Right.
why would
Right.
we
Yeah.
never talk about
Mhm.
that,
I,
And I
I
think,
think it would be great.
we
Yeah.
should
I
just do a
think.
research project.
Yeah.
Yeah. I think that's
Yeah.
so important.
Yeah.
If we normalize talking about, men taking paternity leave, men advocating
Mhm.
for themselves, saying, I want paternity leave, like that
Right.
would really change the environment. It would just
Right.
show us that, okay, when you have a colleague who, goes on, who's pregnant and then she goes on maternity leave, you don't have any of those socially determined like negative thoughts about, okay, why is she
Mm.
going on extra vacation, or you don't get those thoughts anymore, because guess what,
Yeah.
you're going to take paternity leave in 6 months, right? So
Right.
um
Yeah.
Right.
I do think we need more, he for she, in that sense, that we need men
Mhm.
to talk about it more. Having this podcast, being able to um shed light on that this is an important topic for you, right? For you,
Mhm.
Right.
both. So I think we need to also, on higher leadership levels too, being able to, um, have these conversations and advocate for
Mhm.
women, and advocate,
Mhm.
for men too, about
Mhm.
career planning and family planning, that they coexist
Mhm.
together. And then,
Right.
and then, we've I encourage people to also, get involved at the organizational level, like professional societies. I think that a
Mhm.
lot of this work came out from just, my co-resident and I sitting in our resident room, just like how
Right.
your podcast was born. We were just talking, and
Mhm.
talking about, some of the difficulties and challenges that um,
Mhm.
that existed, and how, we're like, nobody's talking about this. Why isn't anybody talking
Right.
about this? So we were like, well,
Yeah.
let's form a group. And, we started, getting people to join Swaro. And then, now it's
Mhm.
like, there's like, it's like its own, formal society, where there's like formal elections, and, people are super passionate, super involved. It's amazing to see Swaro grow. And so,
Mhm.
Mhm.
um, it's really just kind of, these ground level like discussions that spawn into these big
Mhm.
movements. So I think that
Mhm.
the things that y'all are doing to
Mhm.
bring light to this is really tremendous.
Yeah, yeah, and thank you,
Mhm.
because
Thank you.
people like you doing research on this is how we found you and be able to talk about
Yeah.
this.
Yeah.
Um, and I do think that, yeah, on the resident level, we probably need to be to be a little bit more vocal about these issues. Who else is in this space, kind of working towards some of these changes on like a policy level that you would want us to know?
Yeah, Arrow does a great job. They work
Mhm.
with the Astro leadership. They've also communicated a ton with ABR. It's been amazing to see Arrow advocate for all the residents, and so I think
Mhm.
Arrow does like an amazing job. And they're just, we've really made changes. I mean, if you look at even ABR,
Mhm.
um, before y'all started residency, it was like it was, one exam date for oral boards. You had to
Hmm.
travel somewhere. All we still have, unfortunately, rad biophysics and clinical writtens that are all, separate exams. But you know, um, we had a lot of discussion with the ABR about, what flexibility looks like, how this is difficult for people who are trying to take care of children and trying to juggle all of
Hmm.
that with like such a rigid schedule, and people were like planning their pregnancies around these exams.
Hmm.
So
Right.
and they've made really substantial changes, and it's been amazing to see. I think that
That's
um
awesome. Hmm.
yeah, we did a survey study of trainees with and their impact of the ABR boards on them, and we were able to report that, and they took that
Mm.
into consideration. So um there's a lot of organizations, starting to really um understand, but make actual changes. And even at the residency level, you can have a certain number of weeks without having to extend your training.
Right.
So
Hmm.
Right.
yeah, so
Right.
there
Right.
are definitely changes that are happening.
Right. Yeah. So
Hmm.
one of our discussions in the coming few days or weeks is with a resident from Stanford. Her name is Dr. Banio, who wrote a paper about some of the policy changes around, family leave and medical leave in
Medical
residency.
leave.
And
Oh.
like you said in the beginning, like a lot of this was like very sounded very suggestive, and like programs didn't really follow through initially. But now I think that the next step that governing organizations are taking is to actually make it not just a recommendation, but actually like
Yeah.
a mandate kind of thing, so
Mhm.
that
Hmm.
people can people can have that structure, and
Mhm.
and know and be confident that they're being protected in those
Yes.
ways. Yeah.
That's right.
Hmm.
Yeah.
Dr. Lee, how do we, we, like you mentioned, Arrow, these organization within our field, but how do we kind of advocate on a larger level? Do you work with the medical oncology kind of organizations that are similar to Swaro or the surgical oncology side? Is there any type of national push?
Not that I not that I know of, but that doesn't mean it doesn't exist.
Mhm.
I
Right.
think
Yeah.
that that would be great. I think that even like ASCO, larger organizations, society level organizations are starting to um,
Mhm.
make changes like incrementally, so even at conferences they have like pumping stations, or I think it's less frowned upon to like bring your child to a conference. People are doing that more and more, and I think that
Mhm.
is especially, young children where you have difficulty leaving them at home, or if you're breastfeeding and
Mhm.
you need to bring the child. I think that people
Mhm.
are being more receptive and open to that, and I think this at the society level, they're I think eventually we'll get to a point where they'll encourage that. So,
Mhm.
and
Right.
then some societies are providing like subsidized or free childcare on the premises for, parents who want to enjoy the conference. So, um, I think incremental changes are being made. It would be nice to see, higher policy level, more, more concerted efforts. I'm not
Mhm.
sure what that would, entail, or what that would take to get there, but that would
Mhm.
be nice to see eventually.
Yeah. Yeah.
Yeah. So, Dr. Lee, thank you, so much for joining us. I think what you're doing, I think really lays the foundation of having a huge impact on the field in general, on fertility, family planning, career decisions, all really important topics. And, I hope that when I have kids, I also get paternity leave. So, so thank you.
Yeah.
Is for others, also interested in
Mhm.
kind of learning more about this topic or potentially getting more involved in this area, are there other resources, organizations that you'd recommend they look to? And is there any way they can contact you?
Yes. So we have, for trainees, we have SWARO, the Society for Women in Radiation Oncology. It's free to join. And
Mhm.
I would definitely recommend getting involved in Arrow. And then, at the once you're an attending, or even, if you're not attending, even as a trainee, you can join AAWR, which is the American Association of Women in Radiation and Radiology and Radiation Oncology. And then we
Hmm.
also have the
Mhm.
Rad Onc Women's Physicians Group, which is a Facebook group dedicated to
Okay.
women in our field, and it's like a very safe space. You can, talk about anything. I really enjoy being part of that community, promoting and cultivating a culture where anybody can feel safe and anybody can feel like they're being supported in their family planning endeavors, but also in their career. So,
Mhm.
being very encouraging and supportive when you have a colleague who's, about to go on leave. I think that still women feel like, if they're about to go on leave, they have to, make up for what, the time that they're going to be gone for, and they feel like the sense of guilt. But, we should all celebrate one another in terms of, all of our achievements and all of our, the things that we want in our lives. So I think that's,
Mhm.
overall just important to just having an overall long, successful, and being very satisfied in our careers. And then
Mhm.
I do want to highlight that we have a qualitative study coming out. So this is, we have a section where throughout the survey where you could, write in free response text. And so we did analyze them, and we just submitted our manuscript. So, look out for that. I
Awesome.
think it's
Okay.
Mhm.
extremely eye-opening to hear and read about some of, like, quotes from women who filled out our
Mhm.
survey. So it'll be very informative as well.
Hmm.
Awesome. And one final question before we let you go. What do you do for fun when you're not working as an oncologist?
Um, so yeah, I think when I was a trainee, I feel like I just didn't have enough fun and take time to pursue my personal interests. But
Mhm.
I uh, travel a lot with my husband, and locally I've been taking like ballet classes and Orange Theory classes, and
Oh, very cool.
yeah, I joined the
Oh.
local orchestra, and like I'm in a book
Oh,
club.
wow.
So yeah, I think it's really important to, have a life outside of work, and
Yeah.
it's been really nice to just like take time to enjoy life. And I didn't
Right.
have that before. I think I was so like stressed out about, finding a job and getting the perfect job that I wanted. So
Right.
Mm.
yeah, and I feel like now I'm really taking time to think about like what's important in my life, like um how do I want to spend my time when I'm not working. So
Right.
I'm trying to be very intentional and about everything that I do. And I forgot to
Uh,
mention though that, if anybody, wants to reach out, I can leave
Mhm.
my email address with you
mhm.
so you can share.
Yes.
Great.
Yes, yes. Thank you very much. So, listeners, this is our conversation with Dr. Lee. She's been very helpful, and it's been an enlightening conversation. And we hope to someday maybe have a comeback and discuss some of her studies that she puts out there.
Okay.
Dr. Lee, thank you for joining us, and
Yeah, thank
I'm
you.
sure we'll catch you at some Astro meeting or like Acro or whatever meetings that we all have in common.
Thank you so much.
Okay, listeners, thank you for tuning in to Tumor Board this week. We hope that you took something away from this episode. And if you like what we're doing, please rate us 5 stars and like this episode. You can also follow us on Spotify, Apple Podcasts, YouTube, and any other platform that you get your podcast from.
We hope by now you realize our goal is creating a platform for under-discussed topics in medicine. If you have any questions, comments, or topics you want us to talk about, you could reach out to us via email or Twitter. Our handle is @TumorBoard. Thank you.